Good afternoon, everyone. I'm glad you all made it here before the skies open, which it looks like they're about to do. So I am delighted to introduce to you Dr. Jim Buehler, who is the Health Commissioner for the City of Philadelphia. But as many of you know, Dr. Buehler took a leave of absence from his faculty position in the Department of Health Management and Policy, my department, here at Drexel, when he was asked by Mayor Nutter to serve the City of Philadelphia as its Health Commissioner starting last July. Dr. Buehler has more than 30 years of public health experience, having served as commissioned officer in the U.S. Public Health Service, senior scientist at the U.S. Centers for Disease Control and Prevention in Atlanta, and professor at Emory University's Rollins School of Public Health. Please join me in welcoming back Dr. Buehler as he tells us about his year in the life in the Philadelphia Department of Health.
Thanks very much. Thanks very much for having me today. I have a very vivid memory of being in this audience about a year ago when Don Schwartz was standing here giving the talk on behalf of the Health Department and thinking what a tremendous leader he is, what a tremendous set of accomplishments and progress that he's made, what a wonderful health department we have in this city, what a great group of people that we're fortunate to have in the health department. And at that time, if you had asked me what's the likelihood that I would be standing in this position today, I would have put the odds at zero. It's amazing how careers can take turns and opportunities to present themselves. So for those of you that remember Dr. Schwartz's talk last year, you'll note that mine's going to take a little bit of a different tack. Like Dr. Schwartz, I will provide some overview of the mission and functions of the Philadelphia Department of Public Health. But then I want to illustrate those missions and functions and how the health department achieves them and does that through a variety of different examples that have just come up since last July, which is when I came into this position. And then Jennifer also asked me if I would provide a few reflections on what it is to be in this role. So our mission is to protect and promote the health of the people of Philadelphia, of all Philadelphians. And in addition to that, we provide a variety of safety net services for the most vulnerable. We do this not only through the energy and skill and enthusiasm of our staff, but also through a wide variety of collaborations and partnerships with other government agencies in different parts of the city, at the state, and at the federal government level, with non-governmental organizations and other community-based organizations throughout the city, with healthcare providers and insurers, with universities, of course, businesses, and others. We work in a broad array of areas, and if you look at the sets of functions that health departments have under them or within their umbrella, we're pretty big in terms of the set of things that we have. The main thing that we don't have is mental or behavioral health services, which is in a fellow department under the same deputy mayor. We have the full spectrum of infectious disease prevention and control activities, including general activities as well as categorical activities like HIV, STD, TB, hepatitis, and immunization program. We have an active chronic disease prevention program that's focused mainly on tobacco cessation and healthy eating, called Get Healthy Philly. We have a variety of maternal and child health services. In the area of environmental health, we work in food service protection, restaurant inspections, rodent and vector control. So this picture from 1914 is our rodent program is a descendant of that from over 100 years ago. We do healthy homes work to address health issues that are arising from unfortunate housing conditions as well as air quality. The medical examiner's office is part of our department. We operate 8 primary care clinics, and we run a public health laboratory that serves both the clinics as well as the epidemiologic functions of the health department. We try to base what we do on the evidence. What's the evidence? What's the health status of the people of Philadelphia? Our focus is on prevention. We try to track the various dimensions of who, what, when, where, and to the extent possible, why. How are things changing over time? Where are the health disparities? What are the risk factors, the antecedents for disease, the disease characteristics, or the outcome? And where in that spectrum of points are there potential interventions that we need to consider, what the costs are, what the feasibility is, and what the potential impacts are, and what are our resources to be able to address that. And then what do we and others need to do to achieve the desired impact, and then ultimately what is the impact. This is our aspiration. I can't say that we accomplish this cascade of steps for everything that we do, but this is what we strive to do. I'm not going to show a lot of data slides because this is really the only slide that you need to see. This is a map of the percentage of the population living below the poverty level at 2 slices in time, most recently 2010 in Philadelphia. For those of you that are familiar with this city, this is a familiar picture. But virtually any other slide that I would show you that looked at adverse health outcomes would look a lot like that. And that reflects the understanding that we all realize of the association between poverty and poor health. So I'm going to move now to just a series of slides that are in the format of showing you an illustration that illustrates one dimensions of our program, and then talk through a little bit about that. So if you were at on the Market Frankfurt line, you might have seen this while you were waiting for the subway. This is having a stroke can change your life, and this is part of our salt reduction program. Well, what's behind that? What's behind that is what we know about high rates of cardiovascular disease in our city. What's behind it is what we know about disparities by race and ethnicity and poverty. And what we know is about the high risk or the risk associated with excessive salt intake as a contributor to cardiovascular disease. This program was launched with funding from CDC, and at the outset we did a formative evaluation, talked to people in the target community, and learned that of the adverse outcomes of cardiovascular disease, stroke is one of the more feared outcomes. It's one that gets people's attention. And then we also learned, where do people go? Where are they? What are the communications venues that they're likely to be exposed to? And targeted our campaign, our educational campaign, towards that. And there will be an evaluation that's built into that. In 2008, Philadelphia enacted a law, and this is a copy of that ordinance, that requires calorie, sodium, fat, and carbohydrate counts on menus at full-service restaurant chains with over so many stores. The law was enacted in 2008, but didn't actually go into effect, or rather it was passed in 2008. It didn't go into effect until 2010. The evaluation that's been done of that, Amy Auchincloss here was a lead author on that evaluation, demonstrated that when you compared chain restaurants inside the city with chain restaurants from the same company outside the city, consumers that purchase food at the restaurants with the menu labels tended to buy foods with less sodium, less carbohydrate, less fat. But 2010 federal law that prescribed menu labeling preempts our law. And one distinction between the federal law and ours is that the federal law does not include a provision to require sodium labels. So while we've put our law into effect, and while many restaurants are adhering to that, and while looking at the restaurant menus are part of our food service routine, we do not, because of the federal preemption, have the authority to issue citations or fines if people are in violation. So we have applied to the FDA for an exemption to be able to implement our own version of the law. And part of the consideration there was, should we just let go of the sodium label requirement and adopt the federal law, or should we try to stick it out and get that exemption? We decided for the latter. In that application, we argued that this is a local response to a local problem. The local law predates the federal law, and restaurants are generally complying, as you can see from a couple of menu illustrations here. This photograph was taken at the main library downtown, and it was an event where the Get Healthy Philly program sponsored a cooking contest for teams from different high schools in the area. The charge was to develop and execute a breakfast that could be made for a certain amount of money, that could be made that met certain calorie requirements, that met certain the appropriate nutritional standards, and then they came in for this cook-off, the different teams. Seated at the table are the judges to judge the entries. That includes school cafeteria managers, local restaurateurs, and students. The guy without a lot of hair that's in the near side is Mark Vetri, who runs the Pizzeria Vetri and Osteria and a number of other prominent restaurants around town. It was interesting as the judges were reviewing one of the entries, he said, "You know, this was really good, but I'd add a little salt." and the student said, "Well, we're not allowed to use salt." He took that recommendation back. But this work with school kids and schools is just one dimension of a number of efforts made by the Philadelphia School Department, both before and since the current administration, to enhance the food security for poor children and enhance the quality of food. I'm not going to go through the specific bullet points here, but the initial bullet points represented efforts that the school district made to move away from providing free meals to individual students to being authorized to provide free meals for every student in neighborhoods where a very high percentage would meet that criteria, as well as to provide education from them. Then there were efforts to improve the quality of the food, the nutritional content through school nutrition policies. And then more recently, provisions to use 1% milk, to avoid using fryers, to set up school wellness programs that included students and parents and teachers and principals. And the graph on the left shows some of the things that they did, like setting up a policy where if the teacher wanted to reward the kids in classroom, they wouldn't do it with candy, but with some other incentive. Or if the school was having a fundraiser, you wouldn't sell candy or nutritious food to do that. Or programs to build into recess time or just mini breaks, a chance to get up and move around. And also moving away from sort of prepared meals that just get stuck in a microwave to meals that are actually prepared in cafeterias. So it's improving access to food, improving the quality of food, but also changing the mindset about food among young people. And we've seen in Philadelphia over a number of years a gradual decline in the prevalence of childhood obesity. Now, for my fellow epidemiologists in the room, you would cringe at the fact that the vertical axis doesn't go down to zero and that this tends to overemphasize what may be relatively modest changes, but these are actually significant changes. We see this decline in childhood obesity through measurements that are taken at the school, and this is done in collaboration with the school district across both male and female students. The picture's a little different when you start to break it out by race and ethnicity, though. This past September, the state legislature passed a law that allowed the city of Philadelphia to add a $2 a pack surcharge or tax to cigarettes. That tax gets applied before you come to the cash register. It happens at the level of the distributors to the retailer. This is a substantial public health accomplishment. The tax was sold, though, not on the basis of its public health impact, but on the basis of its revenue impact for the schools. Although the public health department was very much involved in the background, in the policy analysis, and preparation work for this. That included reviewing the literature to examine what's known about the relationship between tobacco prices and tobacco use across different age groups, what's known about tax avoidance strategies, if there's a differential on one side of the county line versus the other, what's known about price-dependent reductions in smoking, and that went into the revenue projections that were used in making the case for that tax. But we also were aware that there would be substantial reductions in smoking based on the literature and attendant with that substantial public health benefits. So now as a result of this tax, the average price of a pack of cigarettes in the city of Philadelphia is $7.85. And coincident with the implementation of that tax has been a surge of interest in quitting. We've seen a 50% increase in calls to the quit line, 1-800-QUIT-NOW. A few businesses have quit selling tobacco altogether, and based on the initial implementation of the law, if you projected that out over the course of the year, it'll probably generate around $60 million. But the story isn't over. Before I tell you the story isn't over, let me just show you with cigarette smoking trends. These are data from the community telephone survey done by the Public Health Management Corporation, and across the slide are different interventions that have been put in place over the years. I apologize that it's hard to see, but they include some other increases in taxes, anti-smoking campaigns, giveaways for nicotine replacement therapy, a variety of other programs and interventions. It's really too early to see the impact of the tax that went into effect back in November. So the legislative story isn't over. One aspect of the state law that gave us the permission, or gave the city permission to implement the $2 pack tax, was a provision that it was going to sunset in 5 years. Another provision of that law was that it included the opportunity for an entity that applied for a charter school that was denied that application to appeal. So you might say, what does that have to do with cigarette taxes? Well, the cigarette tax was based on the impact for schools, so that must have been the entree to put that in there. In the governor's proposed budget, which he unveiled several weeks ago, that budget eliminates the Philadelphia tax entirely. It implements a statewide $1 pack tax. It has no sunset provision, and it includes other strategies to adequately fund schools, including schools in Philadelphia. So the mayor and the school superintendent have wholeheartedly endorsed that. But we have some qualms about the public health consequences of that. We would take away the movement across the street to buy tobacco outside of the city, because the tax would be uniform. But it would lower the price, and there would likely be some increase in smoking. So we all know that the governor's budget that's proposed isn't always the governor's budget that's enacted, and so we will hope to have a voice in perhaps some of the back and forth that might occur as other strategies might be considered. We also learned through our group that keeps a very close eye on what's going on in Harrisburg that a state senator recently introduced a bill that deep within it has a sentence that would preempt local authority to regulate or tax tobacco. And we are also making our argument against that known. There's also a variety of local actions. Back in 2007, 2008, City Council passed an ordinance that prohibits smoking in restaurants and bars and indoor spaces, public spaces. And But part of the compromise to get that bill passed was a provision that small neighborhood bars for a very short period of time, I think a 60-day period, could apply for a waiver or an exemption. So some of those waivers were granted. It was never intended to be reopened, but periodically city council members have introduced bills that would grant a waiver to a club, a small club in their neighborhood. Last fall, we saw 4 of these come through all at once and decided, well, it's time to speak up. We testified against granting those waivers. City council decided to hold the bills. They came back a few months later and passed those 4 bills, but at the same time promised that we're going to pass these, but we're not going to open Pandora's box. We're going to put in legislation that shuts the door on waivers in the future, and that bill did just recently pass. And we were very involved in working with the mayor's legislative aid to help make that happen. One of the major events that had happened over the past year is the Ebola crisis. And you might recall that initially the CDC position was that any hospital that can provide inpatient services at a certain level should be able to care for a patient with Ebola with standard infection control techniques. That policy evaporated as a result of what happened at the hospital in Dallas, and over a period of weeks, the guidelines for caring for Ebola patients and the approach to that strategy changed. But there was also a tremendous angst in our West African community. We have a very large West African population, most of that actually here in West Philadelphia, with people from all 3 of the countries that were heavily affected. This photograph was from the paper, from a march that was made. The woman that's featured prominently here spoke at a rally that concluded the march and gave a very heart-wrenching story of going to the doctor's office for, I think, a rash that in no way fit the possible symptoms of Ebola. Although she is of West African descent, she had not traveled to Africa within months, certainly not within the 21-day incubation period of Ebola. And yet, as a consequence of her visiting the doctor, she was sequestered away in a remote part of a clinic. Ambulance was called, emergency technicians came in protective gear, took her to one of the higher level hospitals. She was evaluated, diagnosed as having an allergic reaction to a medication, and sent home. That's terribly traumatizing to somebody. And that kind of experience leads people to say, well, I'm not going to go to the doctor, which is exactly what you don't want people to do. And so the West African community mobilized to draw attention to their concerns. At the height of the public anxiety about Ebola, Mayor Nutter convened a press briefing and brought his health commissioner, fire commissioner, which runs emergency medical services, emergency manager, and the airport director to stand behind him and contribute to that. So the Ebola response had many different dimensions. It was built on our existing emergency preparedness plan and partnership, which includes ongoing relationships with hospitals throughout the community and the hospital association, with infectious disease physicians. We dusted off our quarantine laws to make sure they were up to date. There was substantial communications activity. We took materials from other health departments, from the CDC, put our logo on, got it out there. We met with organizations that represent the different West African communities. I testified along with others at a city council hearing and participated in the mayor's press briefing, and we dealt with any number of media inquiries. We collaborated with CDC, the state health department, and selected hospitals to work with a few of them to become higher level centers in the event that we would care for an Ebola patient. Our medical examiner reviewed policies and procedures for safe disposal of a body if we did face that situation. And we, for a number of months, are in contact by telephone with everybody that's within 21 days of returning from those 3 countries. As of a couple weeks ago, we've been in touch with 450 individuals. Pennsylvania or Philadelphia gets roughly 5% of all the people that are coming into this country from those countries. On a given day, we're making 30 to 50 phone calls 7 days a week. We follow them out to 21 days after their departure. A very small number of people have actually required further medical evaluation, and none of them have had Ebola. We've seen malaria, dysentery, and other diseases. Another major event this past year was the measles outbreak that started in California. And there were a few cases here in Pennsylvania, but fortunately none in Philadelphia. But it calls attention to our immunization program. We are one of a few localities that are directly funded by the CDC immunization program. Local health departments love to be directly funded by the federal government as opposed to having their money go through the state. And this is one of the CDC programs that directly funds different localities, including our health department. The Vaccine for Children's program, which is a federal entitlement program that's administered by CDC through state and local health departments. In Philadelphia, provides 70% of all vaccines that are delivered to people less than 18 years of age. We have very high levels of measles coverage. The percentage of children 19 to 35 months of age with 1 or more measles vaccine doses is 96% in Philadelphia, which is higher than the rest of the state and higher than the national average. Now going forward, there's an effort to, as in many states, to review our exemption policies to see if that should be tightened up. Another concern that we have is that under the Affordable Care Act, there were policies to enhance Medicaid reimbursement to private providers who are providing certain preventive healthcare services. Those enhancements went away January 1st, and we have some concern that that might be a disincentive to providing vaccination services. So more to come in terms of the policy and legislative horizon. And this is a map that's a little different from many of the maps. The darker colors are the areas with higher levels of vaccine coverage overall. The reason that it's not higher than 77% is typically because of the 4th dose of DTP, which tends to be a little later in some instances. But what you'll notice is that map that showed poverty rates, the areas that had high levels of poverty roughly tend to have higher levels of vaccine coverage. That's, I think, a testament to the public funded Vaccine for Children's program and our partnership with the pediatricians and family practice providers and health centers throughout the city. If you read the Philadelphia Inquirer, you might recall that on January 15th, they put out a big story about restaurant inspections here. And the photocopy is a little faded, but it says that, let me turn. The city tries to protect diners, inspecting facilities and posting reports online. But unlike many cities, there are no overall grades. And it goes on to say that our reports online are obtuse and difficult to read, which they absolutely are. And then this newspaper series directs you to a web page that the Inquirer operates that extracts the data from our online reports and tries to present them in a more user-friendly way. There's actually another group that did something similar to that a little ahead of the Inquirer, but there are now 2 utilities where you can go online and, if you want, plan your dinner, make your dinner plans around their composite synthesis of our restaurant evaluation. But this is an area where I think the health department's made tremendous advances. We inspect over 12,000 licensed restaurants or facilities a year. That includes restaurants. As a part of that is a menu label review. We also make sure they're not using any trans fats. It includes retail food stores, mobile food vendors, and institutional providers. We try to get to the restaurants once a year. Some of the others that are either more high risk or serve a high risk clientele, like some of the institutional facilities we see more often. Our food service also investigates foodborne illness and complaint investigations. We promote a food safety certification program. You can't serve food unless you have on the premises somebody that at all times that has that certification. When businesses seek to get into the food business, we review their plans, the physical layout, and their proposal for how they're going to run the business. We do pre-licensure inspections, which then gives them the okay to seek their license. We also are involved with special events and summer food program. Things on the horizon for us here are to try to meet our goal of getting to those restaurants once a year. We've made some progress. It's gone from every 17.6 months a few years ago to 14.6 in FY14. We've created some new sanitarian positions. We're trying to speed up our hiring procedures to make that goal. We also aim to re-inspect within 30 days restaurants that have concerns noted. If we actually close a restaurant, we get back much sooner than that. We're also working to enhance the consistency of the restaurant reviews. So we've had over a 6-month period. All of our sanitarians have come in for half a day to have uniformity training. That was just completed as part of a broader quality improvement program. All of our data are online, but to be honest, the forms that we put online were made for sanitarians, not for anybody who isn't a sanitarian. So we're also thinking about what we can do to improve the transparency of that information. And we've thought a lot about this question of whether to offer grades or not. So far we've concluded no, that the literature shows that there are substantial pluses and minuses to doing that. Our impression based on the review of the literature is that the disadvantages outweigh the advantages. And we are working to upgrade our services for vendors. So more and more of procedures are online, and we're also working to provide more educational material so vendors understand the process. We stole from New York City the title, What to Expect When You're Inspected, for our pamphlets. Many people in Philadelphia live in substandard housing. Much of that housing is rental housing, and there are a host of health problems that can be aggravated by poor housing, from safety risks to exposure to allergens that can aggravate asthma. This is from a report that was done by Child Health Watch a few years ago on housing insecurity, and a substantial proportion of families in this city are insecure in their housing, either because they're required to make frequent moves, they're behind in their rent, or they're living in crowded conditions. And all of this increases the likelihood of being exposed to substandard housing. With HUD funding and in collaboration with St. Christopher a couple years ago, we did a pilot with 120 kids with severe asthma. Went to the houses, inspected them, did a bunch of, did physical remediation, took out the old carpet, patched the roof, got rid of clutter, did motivational interviews and talked about removing noxious exposures. And when that program was evaluated, we saw substantial reductions before and after in emergency department visits, doctors' visits for poor asthma control, the use of nebulizers, hospitalizations, and days of missed school. And now we're seeking to expand that to to children with asthma in a couple of our health centers and collaborating with the License and Inspections Department because many of the places where kids are living in substandard environments are rental properties, often with multiple code violations. We're trying to coordinate that with L&I. As I mentioned, we run 8 community health centers. This is from a poster contest. We see about 80,000 people a year who make over 300,000 visits. Roughly half are insured, most of that with Medicaid or Medicare. Just last week, PHMC unveiled the findings from the latest iteration of their survey, which showed that from the last round in 2012, the percentage of people 18 to 64 who are uninsured dropped from 18.5% to 12.3%. That's a substantial effect, and that's before the Medicaid expansion. But it had a very small impact on the patients in our population because with the federal exchanges, in the absence of a Medicaid expansion, most of our uninsured patients didn't fall into eligibility for private insurance through the exchange. Medicaid expansion was initiated in January. I think everyone's probably familiar with the fact that the way that's being done is, as initially proposed by Governor Corbett, is now being converted to a more traditional Medicaid approach under the Wolf administration. We expect the impact of that to be substantial on our patients, although it's hard to predict exactly what that will be. And we have benefits counselors in each of our clinics, and we work with a variety of community organizations that are out in communities trying to encourage people to get insured. We're working to install an electronic health record, and we're seeing all the issues that the rest of the world is seeing. That was implemented in 2 phases. First, the practice management system, then the medical record component, and now, to use our IT words from our IT friends, optimization, making sure that we have the capacities to have information handshakes with other providers, making sure that we can use the database that sits underneath that to analyze that, to do different performance monitoring, to fulfill our requirements to the federal government under the Meaningful Use program to apply for patient-centered medical home status. Trying to think about how then to extend this to the TB clinic, interface with the STD clinic, our labs and clinical pharmacies, and a patient portal. So we've done a lot more to go. And this is one of any number of articles talking about the vast sums of money, frustrating software, angry doctors facing a punch in the wallet, and a hungry new Congress could prove a powerful threat to the Obama administration's $30 billion program to digitize our medical health records. And so we get to see this from both sides. One of the interesting things about this health department is that we see the public healthcare interface up close. The Pope is coming. Why am I showing you a picture of the Pope? Well, there's going to be up to 2 million people out on the mall. And they're going to be here on a Saturday and Sunday. So we're going to ramp up our disease surveillance activities. We probably supplement our air sampling for biological hazards. Our public health laboratory will be on the standby. We will be conducting investigations as responses as indicated. We'll be working with our colleagues in the healthcare community as well as general healthcare messages. We'll work closely with the state health department and CDC. Our food service folks are going to crank up the special event procedures. All the food that's served inside that perimeter, we will inspect that. We work with the FDA. The FDA is going to actually sample all the food that's served to the VIP party, and they're going to put that away somewhere. And if anybody gets sick, they'll look at it. The jargon that I learned in the business for those plates of those food that gets sequestered away is called the dead man's plate. Let's hope that doesn't come to pass. And then we'll be beefing up our rat control and mosquito control. So this is one division. The director of this division, when we met to talk about what are we going to do, she said, my goal is to make sure the Pope doesn't get foodborne illness, that he doesn't see a rat, and that he doesn't get West Nile virus from a mosquito bite. So if none of that happens, we'll be very happy. And if any of you have not seen a rat today, thank our program for that. And there's a huge federal government comes in and takes over, and we connect to all of that. So one of the parts of the department that when I came into the job, I got pretty familiar with some of the areas that we work in and not too familiar with others. This was one that was where I've learned a lot. This is a photograph of a solar-powered air monitoring, a solar and wind-powered air monitoring station that looks like a park bench that tracks ozone layers, ozone levels, and small particulate matter. The image here is concealing the little table that you can put your phone up to, and the reader will connect you to a web page, and you can see what the ozone levels are, or the PM 2.5 levels. This is right out in the front yard of the Independence Hall Museum, and Philadelphia is one of 6 cities that successfully competed for this pilot test, which aims to test this new technology, as well as generate public interest in air quality. Actually, the photograph and the insert was taken yesterday when this was dedicated. I had a chance to speak with the regional EPA administrator and the administrator for the Park Service administrator, and actually be introduced by Benjamin Franklin, who's standing there on the left corner. So this is the Village Green pilot, but for over 50 years we've been monitoring air quality for multiple pollutants, 11 fixed sites around the city. We also have a substantial regulatory function. We permit, when you drive down to the airport and see the refineries, we permit them and others that are putting stuff into the air. We monitor and enforce that, including fines. We also work with a variety of organizations in the community to do projects that support cleaner air. For example, we have the diesel retrofit program in collaboration with the Clean Air Council. And we've seen substantial improvements in air quality over the past 15 to 20 years. So Jennifer asked me to talk a little bit about what it's like to be health commissioner. And I actually don't own either of these 2 books. But I have a childhood friend, this guy I've known since I was 8 years old, and we've stayed in touch all these years. He just became the president of a large Big Ten university in the Midwest. And I saw him a week or 2 ago, and I said, Michael, how is it? How's your job? And he said, it's a tremendous opportunity, and I could tell that he relished that opportunity. But he also said it's not an easy job. And that's what it's like to be health commissioner. But I'm not going to talk about the issues of leadership and management. I just want to give a few snapshots that provide some glimpse into that. So partnerships are very important, and work with many different partners. This is from the opening of a neighborhood farmers market, part of a larger program that we have in collaboration with a variety of groups, the Food Trust, the YMCA, and a company, Green Mountain Energy. This photograph was taken from Green Mountain Energy's webpage. You might guess which guy in the picture is from Green Mountain Energy. And it's also an important reminder that the health commissioner, and by extension the public health department, is not necessarily the most important person. The guy without his head there. There's also a symbolic and ceremonial role to the job. So this is from the groundbreaking of the new public safety building, or this is an old building that's being renovated for public safety in West Philadelphia, and this is the groundbreaking for that. So they cover the ground with artificial turf. They carefully put out a row of soil, and they give us a shovel, and we're very carefully orchestrated. It's like 1, 2, 3. But it's also a chance to meet to get to talk with our colleagues in other parts of the city, so the police commissioner, the councilwoman for the district, obviously Mayor Nutter, the chief of staff, and public safety director, and another person for public safety. This is my boss right here, Susan Kretsky, who's the deputy mayor for Hampton Opportunity. We have to be accountable, which part of the job is testifying. A week from today will be, for me personally, the end of when I can say I'm new, when I sit before the city council and defend our budget. There are parts of the job that have a very solemn responsibility. This photograph is from a motorcade earlier this year where the police were carrying the body of a fallen comrade who was shot. They're on their way to the medical examiner's office, which is part of our department. And there's a protocol, a tradition in the office that comes into play when an unfortunate event like this happens. But it touches all of us. Our workforce is unionized, so everybody except at the upper levels of management belong to a union, either District Council 33 or District Council 47. And that means that our workforce is represented by the unions, and that flavors those interactions. The unions are an important part of our life. They're important in representing our employees, and we work closely with them to address their concerns. Jane Baker is here. Dr. Durdermali is also here. Jane could tell you more about that. There's a certain degree of bureaucracy that goes with the job. This is actually a photograph of my office, the table in my office. And every one of those yellow tabs is a place that I get to offer my signature. And at first I thought, why am I doing this? But actually, it's really great because in that whole stack of paper, per half inch, maybe there's one page that needs to be read, or if it's a renewal, just a sentence or even a phrase. And the rest is all the boilerplate language. But it gives me a chance to see how we're spending our money. Roughly 40% of our operational dollars are spent on contracts. And it's just an opportunity to see who we're contracting with and what they're doing. Many other administrative issues, particularly around hiring. I've learned more about background checks in the past year than I ever imagined that I would come to know. And how to do them responsibly, but also more expeditiously. There's a certain degree of irony. So when the American Heart Association announced that it was going to host its 2019 convention in Philadelphia, which will bring about $60 million worth of convention business, they held a little reception to announce that, and they gave everybody a chocolate heart. Which, this is not a low-fat or low-sugar chocolate heart. And there's sometimes things come up that are unexpected, at least for me, unexpected. So in advance of the Made in America concert last fall, I had probably somewhere in the back of my mind been told that one of the responsibilities of our air management service is that we are responsible for commercial noise control. So this is very noisy, and it occurs out on the mall, and a lot of concerns about that. We're working to deal with these noise issues. But more often than not, it's commercial noise, building construction often. We do a lot of translation. We don't, a lot of times we're not the ones that do the primary research, but we're the ones that take new ideas and put it into action. A good example of that now is pre-exposure prophylaxis for HIV prevention, which is relatively new, and it's been shown to be effective in a variety of clinical trials and formal evaluation settings, and now we're a place that's trying to think about how to responsibly implement this as part of a much broader HIV prevention strategy. Dr. Gold, who sits on the Board of Health, is familiar with our deliberations around that. And we deal with the media. So this is an email that Jeff Moran, our media lead, got in January. Hi, Jeff. Happy New Year. Hope you had a nice holiday. I'm wondering if you have any interesting health medical investigations or stories. Things like dangerous products, places, or people. Let me know, thanks. I would tell the name of the reporter. And I said, Jeff, do you get this kind of message? He said, a lot. He said, they're not usually that blatant about it. And we have a rich history of public health here. I've dabbled a bit in trying to learn a little bit about that. But if you think we play hardball now, go back several hundred years to the colonial era. Many of the issues that we struggle with today, they were struggling with several hundred years ago. But it's on a different stage. But it's interesting. William Penn, when he gave the instructions to his city manager, I want to build a new city, and I want it to do two things. I want it to foster health, and I want it to be good for navigation, which in those days were very interrelated. So the notion of health as a part of who we are goes back to the start. I've given you a sort of very quick, very superficial view of a lot of different things. www.phila.gov/health. There's a separate web page for more technical information. And we also have a presence on social media. So please take a look at that. I probably went a little longer than you wanted me to, but happy to answer questions. And if there's more I can't answer, there's a couple people in the front row that I'm sure will bail me out. So thanks.
You mentioned that when you that the tobacco taxes were passed with a budget and revenue emphasis over a health promotion emphasis, which also seemed to be the approach that Mayor Nutter used when he was doing the soda and sugar-free beverage tax proposal a few years ago. Why is the revenue and budget approach preferred over emphasizing health benefits?
I think it boils down to a political calculation around which approach is likely to result in the outcome you want to get.
Thank you.
Yeah. Yeah.
Just two questions. One is, what fraction of the budget is dedicated to ongoing programs versus sort of responding to? Can you repeat the question?
So I can repeat it. Yeah. Go ahead. So say it again.
What part of the budget is dedicated to ongoing programs as opposed to responding to emergencies or things that you don't sustain? And the second question is, where you didn't have that sort of prescription drug abuse.
Yeah.
Is that in the mental health?
So there's two questions. One is what percentage of our budget is dedicated to sort of developmental or innovative projects, and what percentage is or emergency preparedness. Another is what about prescription drug abuse? So I think I mentioned at the outset that one of the things that we don't have under our umbrella is behavioral and mental health. So the Department of Behavioral Health has the lead for prescription drug abuse. They actually operate methadone clinics and work in that arena. One area where we do have a role, though, is that there was legislation passed last year around nuisance facilities where people might be prescribing prescription or drugs inappropriately, so-called pill mills. And we have a role in enforcing that legislation in collaboration with behavioral mental health, police department, and others. Just now, getting up to the point where we're ready to start to put that in gear. So the prescription drug abuse is not one of our primary responsibilities. A substantial portion of our budget comes from grants from the federal government. And that's for a mix of different ongoing as well as more innovative activities. We get CDCs, the biggest funder, but also money from a variety of other agencies. So I can't say how those different grants break out, but for example, a new innovative grant that we've got is around building partnerships between healthcare and public health for diabetes and cardiovascular disease prevention. Here there actually is the PI on that. So many of the federal grants are, some of the federal grants go to everybody, Others are competitive and tend to be more fostering innovation. So there's the green energy thing, or the air monitoring station. We competed with 20 other cities for that and got it. So a substantial chunk of our grant money is for that kind of innovation. I can't say right off the top of it what percentage that breaks out. Likewise, we do get money from CDC that comes through the state for emergency preparedness. So much of our emergency preparedness function is based on federal grant money.
So I have a somewhat selfish motivation to
Sure.
ask this question. I've been without a refrigerator for a week because of my landlord recently, and I was wondering if there's any laws to protect tenants from having working hunger, so that their landlords have to give them working appliances and make sure that things are in order, or is that just case by case based on contractual
So
obligations?
the short answer to your question is I don't know.
I'm just
The
curious.
longer answer to your question would be that's going to be under the licensing and inspections department. But whether you might be able to get something to happen to your satisfaction in time, it's hard to say. Yeah, I forget his next name. Yeah, I think.
I was wondering, you mentioned kind of the separation between the health department and DBH. I was wondering if there's any moves to kind of more closely coordinate between the two, especially for conditions of addiction that kind of blur the line.
Yeah, so we both answer to the same boss. The deputy mayor for Health and Opportunity is over our department, the Department of Behavioral Health and Mental Disability Services, the Office of Supportive Housing, and DHS, Human Services, the Child Protective Services. So we formally meet. We have projects that are collaborative. For example, we work with DBH around smoking cessation for mental health providers. There are a number of different interactions, but we are sort of organizationally in the same part of the city government. Yeah.
What are some of the challenges that you think PDP will face as a department in the future, in the next decade or two? And are there things that you guys are doing now to anticipate those challenges?
So I think chronic disease prevention is going to become increasingly important. The baby boom generation, which I'm a part of, is going to get older and sicker, and so we have multiple chronic diseases. So I think more and more the chronic diseases are clearly an important part of public health already. They're going to become more important. No, something else that we see right now is that while the interface between public health and healthcare has always been an important part of what we do, that interface is being redefined by health insurance reform and many of the dimensions of that are less visible than just getting access to health insurance. One area where we haven't had substantial involvement other than being at the table around data is the issue of violence as a public health issue. I think this is an issue where we struggle somewhat because many things that are important public health problems, we can say violence is a public health problem, but is it the health department's, is that the health department's responsibility? Many of the things that city government does to advance health aren't necessarily done by us. So when I came in here, I didn't ask, can I be sure I'm not going to get cholera from drinking this water? That's the water department. But we collaborate with the water department on water safety. So that violence is an important issue. I think health information technology is going to become increasingly important. That will grow. We have to figure out how to really make that work. I think here in Philadelphia, we work closely with many different universities, but I don't know that we've strategically taken full advantage of that. So yeah, I think that, who knows? It's hard to look into the future, but those are a few of my thoughts. But the old things are never going to go away. They're always going to be here.
Two questions. Rob
I'll
and
let
then
Jennifer.
Arthur. Rob and then Arthur, and
Okay.
then we have some light refreshments if you can stick
Sure.
around for a little bit.
Speaking of areas where you may or may not have responsibility, are you involved in the bike share program?
we'll be involved with the evaluation of the bike share program. So that's very exciting. And we've worked with street departments around bike lanes, and we develop a bicycles report in collaboration. So yeah, it's not ours, but clearly that maybe Geerther might want to say more, or you might want to talk to Geerther afterwards about how Get Healthy Philly is really works closely with many other city departments. I don't think we've officially declared health and all policy mantra, but in effect it's there.
I just wanted to ask, I have the privilege of serving on the Air Pollution Control Board, and Philadelphia indeed has gotten a lot better in terms of the quality of the air. So we have a ways to go, and I'm wondering, again, this is not exactly a health department issue, but what is the health department able to do, if anything, to put in place some technologies that would continue to help us clean the air, like suggesting, with all the building and growth and such that goes on in the city, that new housing have solar panels as part of it, or that the buses be replaced by cleaner buses, natural gas, electric buses, and so forth. There are things that impact health that may not come under your jurisdiction, but would be important. How does that work with agencies that may have responsibilities in those areas?
Sure, I'd love to hear your answer to that question. But I think one is through our regulatory power. You get the regulations from the federal government. We have regulatory authority as well. So does our regulatory authority allow us to build through that arm incentives for that? We collect fines for violations, and that's a little pot of money that we can use to support innovative, perhaps pilot projects. But I think also just being at the table and being a part, contributing to those conversations at citywide, where it may not be our department that has a lead, but making sure that the health impacts or benefits are considered.
Zoning people who approve, plans for new housing and such.
Yeah. So is there health? Does that?
There's always a health.
Is there health? Well, great. Thanks for the questions.
Thank you
Yeah.
very much for coming.